Hello, everyone. Welcome to a CGD event. Today, we're here to talk about the role of development finance institutions in the health sector. This is very much a hot topic now with the COVID response, but in general, has been a really interesting balance between, on the one hand, the need for economic investments in this sector, the opportunity to engage the private sector for more effective health delivery and also economic growth, but also concerns about equity, about the role of the private sector. Are we exacerbating inequalities, or are we serving the poor and most vulnerable? We have a terrific panel of people working for DFIs, who have worked with DFIs, to think about this from all different perspectives today. So we are really looking forward to a great discussion. We're going to kick off with some opening remarks from my colleague, Julia Kaufman. Julia is a research associate here at the Center for Global Development, and she's going to talk to us a little bit about, at a high level, what are some of the issues to consider in the space. Over to you, Julia.
Thanks, Rachel. And thank you also to our amazing panelists for joining us and our viewers for tuning in. Hunter, could you share the slides? So to briefly motivate the discussion today, I'm going to share a few quick comments based on a recent CGD paper by myself, Rachel, and our colleague Janine Madon-Keller, which focuses specifically on the role of DFC in health, but is relevant to DFIs more broadly as well. Next slide. So as we all know, the COVID-19 pandemic has been and continues to be severely disruptive to the delivery of essential health services and products. And in this context of the pandemic's health and economic consequences, DFIs have already stepped up their support through a lot of new projects and initiatives. But there's certainly still scope for more and better DFI investments that safeguard effectiveness, leverage, and equitable impact as they expand their health portfolios in the coming months and years. Next. So just to look back briefly, the role of DFIs in health has historically been quite limited due to a variety of reasons. But the one barrier I want to reflect on a little bit more in these initial comments is the equity and acceptability of private for-profit health delivery. Because private investments for health have been a bit controversial in this regard, because private sector entities are, by definition, profit-oriented and must secure sustained financial returns from consumers in order to succeed. But in healthcare, and especially in low resource settings, the consumers are often individuals who are burdened by and can even be impoverished by out-of-pocket payments. And then governments represent the other potential consumers for privately offered health products and services, but government budgets for health are highly constrained, even more so amid COVID. And so they have an imperative to prioritize and spend really effectively. And government spending in the private sector can absolutely offer strong value for money, but sometimes private entities end up being unable to deliver that value. So overall, it can be really difficult to identify investment opportunities that achieve for-profit commercial viability alongside equitable health improvement. Now, that being said, this social good calculus must be considered in light of the status quo role of private entities in health and not, an idealized blank state of public-only provision. I think at present, around 40% of LMIC health expenditure is paid out of pocket. So in this current complicated context, how can DFIs invest in health in really high impact ways? Next. In our paper, we highlight 3 priority areas, some of which admittedly may be more feasible or appropriate for some DFIs more than others. The first is expanding manufacturing capacity around the world. So in the short term, DFI investments can support pandemic recovery through COVID vaccine manufacturing, which has taken off quite a bit and received a lot of interest, and we'll get into that more. In the medium term, these investments can improve access to essential medicines through enhanced regional manufacturing hubs. And in the long term, they can help with pandemic preparedness and resilience via a scaled network of vaccine manufacturing facilities. But for all of this to succeed, DFIs will have to coordinate with other global partners and purchasers of these products to link to longer term procurement and demand side decision making. Second, DFIs can also act as venture capital investors across a portfolio of biotech investments like genomic sequencing and new products for neglected tropical diseases and other conditions. And then in addition to creating push incentives to reduce the cost of R&D borne by developers, DFIs can also explore ways to help pull health innovations forward through volume guarantees or other instruments that underwrite public purchasing commitments and guarantee revenues for those taking on most risk. And last, we've all seen that COVID-19 has accelerated the development of different health tech innovations. So DFIs can really move opportunities for more expansive scale up forward and also push these businesses to work towards broader socioeconomic reach and equitable access, which brings me to the last slide. So we put forward 3 core guiding principles for DFI health projects. The first is pro-equity development impact. We, of course, think it's important for DFIs to do more to direct investments to lower income countries, utilize loan conditions, institutionalize relevant performance metrics, and deploy other mechanisms to assess and advance development impact. And we recommend a specific focus on investments that are compatible with countries' own universal health coverage goals by supporting the products and services that public payers could pay for in the long term because they offer strong value. And then across these efforts, accountability and learning processes surrounding equitable impact are also key. The second is additionality, which of course is not unique to health, but in the health context, DFI additionality should involve demonstrating how the investment helps to get the right market incentives or regulations in place in an additional way to increase quality and speed while lowering cost or some combination of these factors, and really interrogate the additionality at the investment selection stage. And last, we have a broad bucket on partnerships and co-financing. And I'll just say that, leveraging different risk appetites across investors and identifying the potential value add and niches of each investor is very important, as is coordinating with bilateral donors and other development partners in the global health space to both help inform a strong investment pipeline and find and screen projects on one end, and to potentially create demand reliability on the other, whereby a purchaser might transition from a donor to a government down the line and engage with those potential events. So that's all from me, really quick overarching comments and ideas, and I'll pass it back over to Rachel and our panelists to discuss these ideas and lots more.
Thank you so much, Julia. That was a terrific framing of some of the issues. So now we're excited to kick off our discussion portion of this event. I think what I'm going to do is offer kind of a high-level prompt to everyone as by way of introduction, give them a chance to respond, and then we're going to open it up for a more interactive, dynamic discussion. So I'd love to start off with Marianne Etchebat. Marianne is the lead and executive director at Merck for Mothers, and she's also a board member at CGD. So we're very grateful for that contribution.
And I think this is a real place that DFCs can act in helping to increase the percentage of private capital investments that are going into the health sector. Because we know in certain instances that many of the solutions, market solutions for health impact are earlier on in their maturation cycle. And so they do need that kind of bridge capital or partnerships with multiple types of funding partners or financing partners in order to meet them where they are and help them mature and get to a place where they can scale. And I think that's exactly why Merck for Mothers is engaging in this space, has partnerships with the US DFC, as well as other financing institutions, because we need to support that evolution and that maturation of these solutions. I think the other place is around this notion of sustainability. I think, Rachel, you mentioned, perhaps some of the challenges between private sector profit motive and equity. I would actually like to challenge that and say that if we're really serious about the S and SDGs, which is about sustainability, we need to develop solutions that have ongoing revenue generating models, because somebody has to pay for this. And we have seen in COVID that budgets are constrained, whether they're philanthropy budgets, development agency budgets, or government budgets. And so if we are not building a market for these essential social goods, we are going to continue to stay in this place where we are not going to get to goals because we just haven't created enough sustainable capacity to meet the needs. And so, with intentionality, with the right measurement tools, we can drive equitable health outcomes through DFI partnerships. And that's, some of the work, as I said, that we've been doing with the DFC. And we want to continue to do, because the other place for the opportunity, and I mentioned the word partnerships, is that it's not just about providing the financing to support these solutions and business models to scale. We need to integrate them into health systems so that those health systems can be resilient and they can be responsive and they can absorb shocks. And to do that, it's more than just financing. It's about working with these companies, with these business, with these innovations to ensure that the work actually reaches the individual at the end. It's linked to service delivery. It's linked to human capacity development, and it's linked to an overarching health system perspective and evaluation.
Thank you, Marianne. I think that's really helpful to start off with. And I very much agree. I mean, I think what we are trying to think about is what's that overlap between where the private sector for-profit motivation actually gets you to the equitable development and health goals we care about. And I think we all agree there is overlap there, and there are opportunities to achieve that impact. And we need to be strategic about how we engage in this sector for that purpose. And I think that's a great transition to go over to some of our colleagues who work directly at the DFIs and are thinking about these issues. So I'm going to go over now to Nafisa Jawani. She is the Managing Director of Health Initiatives at the U.S. International Development Finance Corporation. The U.S. DFC is the U.S. government's development finance institution and has been very active lately in the COVID response and more broadly. So over to you, Nafisa. We'll talk more about the COVID response later, but I think maybe for now, just a high level reflection on some of these questions.
Sure. So again, I want to say thank you to CGD. It's been really lovely to work with you throughout my tenure being at DFC, and it's lovely to be a part of this panel of like-minded folks that I get to work with often as well. So thank you again. I thought I would maybe start off with a reminder of where we are with the global health financing gap. And this is prior to the pandemic. There was an estimated $370 billion financing gap for global health. And if we look at just Africa alone, an annual gap of $66 billion for health financing. So it is clear that our health systems were weak before, incredibly weak, and this has to be the time that we collectively work together to strengthen health systems around the world. Given my background in public health, I am personally and professionally focused on investments around the growing burden of non-communicable diseases in addition to infectious diseases. We know that as countries transition from low income to low middle income, you're not only dying from infectious disease, you're also dying from non-communicable diseases. So we need to focus on how is it that we can put seeds in place to strengthen the health systems to address those types of issues that we're facing around oncology, opportunities around oncology, opportunities to really impact kidney care. Those are the types of things that I know that DFC is at least really committed to looking at and how we can leverage our tools. We've remained committed to increasing access to quality and affordable healthcare delivery and services around the world. And I think it's been great to see the wide spectrum of investments that we have across the global health sector, and that includes WASH, food security, healthcare delivery, and of course, vaccine manufacturing, which has been really incredible to work on with the other DFIs. With respect to the broader DFI community, I think that we are making history. And we're making history through investments to support the decentralization of pharma and vaccine manufacturing. But there is a long road ahead of us, and we need to really be thinking about the long game to ensure sustainability. If we're decentralizing, a subsector in global health, and let's say we're looking at vaccine manufacturing, what are all the things around vaccine manufacturing that need to be financed in order for that to be successful? It was interesting, one of our vice presidents that's been at DFC for decades notably said that the collaboration with the DFIs that he's seeing right now around vaccine manufacturing is something that he's never seen before, which is tremendous. It's exciting. But we really, as DFIs, need to figure out how to work more collaboratively, hand in hand, with our global health stakeholders and the private sector to strengthen the healthcare system and vaccine manufacturing. And I think that there's an opportunity for DFIs to think a little bit more creatively about how to make it easier for the private sector to work with us collectively. So while we are making history right now, I think there's an opportunity for us to do a whole lot more. And there's no more time to wait. The time is now, and the opportunity to make catalytic change, unlike we've ever seen in the global health sector, is today, is now. DFC launched the Global Health and Prosperity Initiative in May of 2020. I do, think that a lot of the success that we're seeing with the Happy Initiative is because of the partnership that we have with the Moms Initiative as well. That was sort of our starting point in a lot of ways, and looking at how DFC can leverage its tools to really impact something in the health sector. We launched this initiative in May of 2020 to catalyze up to $5 billion in investment for projects that support the COVID-19 response, and of course, to build health resiliency. I am really proud to say that DFC has committed almost $600 million for COVID-related investments. That is more than 4 times the agency's 5-year average for all healthcare investments. And our agency has incredible expertise and longstanding relationships that really allowed for us to do this. And since I've arrived, we've really been able to leverage every single one of our tools at the agency to focus on global health investments, whether that's political risk insurance, long-term debt, funds, equity, or TA. We've really been able to think creatively and be a little bit more, I almost want to say boutique in the sense of our approach. Like, what is the challenge and how is it that DFC can really work together across our entire agency to meet those needs? And if it's not us, is there a way for us to collaborate with another partner? It could be another DFI or another agency like USAID.
That's a great
exciting time.
No, that's a great segue too over to Soren and Andresen on these collaborations between DFIs and how you work together as an ecosystem. So Soren is the CEO of the Association of European Development Finance Institutions, and EDFI supports and promotes the work of 15-member DFIs based on their shared mandate to align private investment flows with the SDGs by informing policy, driving innovation in industry standards, and delivering development finance solutions. So over to you, Soren. How do you see the opportunities to engage in this sector going forward? Soren, you're on mute.
Thank you, Rachel. Thank you for bringing us together for this important discussion today. And I'd also like to congratulate Nafisa and DFC for everything you've been able to do over the last year and a half since COVID hit. You were very fast to define your priorities and also to place health alongside other things, for DFIs to be counter-cyclical and to protect jobs and to help protect the staff of clients and so on. You put health right up there as a priority from the beginning, even if it's a relatively small part of what DFIs have been doing traditionally. And I think that was a very, very important call from your side, which also inspired other DFIs to put that front and center. Even if the role of DFIs is growing in investing in healthcare across the broad spectrum, it's clearly still an emerging sector, except for I would say 3 or 4 European DFIs that have prioritized this significantly before COVID. Beyond that, many DFIs are just beginning to really emphasize this and gain more experience. So it's clearly a very critical but also a fast emerging priority. And I very much do agree what you say, that DFI collaboration is important, and we need jointly also to send the right signals about what we are able to offer prospective entrepreneurs and companies in this space. There has been, I mean, we've started out with very significant, you could say, investment opportunities that have been realized in the industry and in manufacturing, and in a way, it's ironic that that I think from a development finance perspective, we have been thinking about commodities as things that you could just export and that were plentiful, and it was just a matter of sourcing the financing and the logistics to get it done. But we've of course learned that even healthcare supply chains need a lot of resilience and are very vulnerable in a situation like the one we faced with the pandemic. But I think that just is an extreme version of something that really underlies the case for much more decentralized production and much more investment in countries that don't have this capacity today. So that's crucial. Just a few considerations to mention in addition to this, three of them maybe. So one is that beyond industry and manufacturing and supply chains, there's a lot that DFIs can do also in project finance and in financing services companies and innovative business models around services. And from a DFI perspective, I would say we are really doing all of these. We are seeing that there's a need to be very flexible about the types of financial instruments that we offer. I mean, we cannot solve this just by doing high return, potentially high risk private equity or venture capital type things, or provide secure loans, which are sort of the classical instruments of DFIs. We need to get much more into flexible types of financing, working capital financing, supply chain financing, guarantees, things that DFIs are able to provide, but that need to be scaled up for this sector. We need to build much more expertise. That's always the case for an emerging sector, but without the expertise and without playbook standards, it's incredibly difficult to succeed and navigate also some of the ethical and reputational challenges that DFIs face. And then finally, I would say I think we can do this and do much more to source more private capital for health sector development without compromising sort of a core tenet of how DFIs work, which is the commercial sustainability, both in the sense of financial viability, but also in terms of having high levels of responsibility in everything that we finance. And so I think we do need innovative partnerships with donor agencies, sometimes to do some of the high impact, high innovation things that are definitely needed. But there's also a lot we can do with the, if you will say, the classic DFI model, but with flexible instruments.
Yeah, that's very helpful, Søren. I think what we're seeing is a need to have a portfolio approach where you're considering the various instruments that are most appropriate for different companies at different stages of development. And we'll talk more about that later. So now for one more perspective from a DFI, we have Patrick Osewe. He is the chief of the health sector group at the Asian Development Bank, where he also provides leadership on health-focused investments from the ADB's private sector operations department. So how are you seeing things from your point of view?
Thank you very much, Rachel, for the invitation and to be part of this esteemed panel. So in the past, the health sector actually got a raw deal because there was competition for resources, from the private sector, from the transport sector, from the urban sector, and so on. But I think that the pandemic has changed the thinking around health. And within our organization, the way we look at it is that the health sector has completely changed and is constantly evolving, and we do not want to waste this crisis. And so with COVID, we initially allocated $20 billion, which was budget support, but we negotiated with the governments that the bulk of that money would go to the health sector. And so we saw massive investments in the health sector, for example, building the testing capacity, ensuring, for example, that PCR machines were up to the primary care level. And the PCR machine is good in that it's not just for COVID, it actually used for 23 other conditions and so on. So using that budget support, we are able to systematically strengthen the health system across many countries. And then for vaccine, we allocated $9 billion to support vaccines, but cleverly we included that it will be for purchase of vaccine, but also expand and strengthen the system for deployment. And that, of course, involves logistics supply management system, improving the communication system for health. And once you improve the logistics supply management, it's not just for vaccines, it's for everything else, for health commodities that you have. Support to the information system not just for COVID, but for other conditions as well. So using the pandemic to strengthen the health system, concurrently supporting countries to accelerate progress towards universal health coverage. And this is where the private sector comes in, because if you look at, for instance, in India, where Prime Minister Modi has pushed an agenda to expand universal health coverage to cover 100 million households in India, that has created a lot of opportunity for private sector, because now every household has $6,500 that they decide where to go, whether they want to go to for healthcare in a private facility or in a government facility. So we are seeing many facilities expanding, many new facilities being created, and the private sector playing a very significant role in terms of innovation, in terms of new facilities. And as a development bank, we're also looking at, because we work across sectors, we know that there are certain shortcomings of the health sector. For instance, the production of human resources for health sector is not the domain of the health sector. You need the education sector. Doctors, nurses, digital health specialists, epidemiologists are all produced and funded by the education sector. So we're very much engaged, collaborating with the education sector to produce the staffing that is required in the new and evolved health sector as we see it over the next 10 years. We are working very closely with the urban sector, because if you look at where we have the largest challenges with this pandemic, it's actually in the major cities. And so very much engaged with the urban sector to address some of the challenges and strengthen some of the weaknesses they have in the urban sector, working with the social protection, because insurance is about social protection. So if you're going to expand health insurance, we need to work very closely with the teams that are working in social protection. So there's a lot of collaboration across many sectors to address some of these issues. And then on the issue of manufacturing, this is a big issue. And it's not just manufacturing. Where the DFIs come in is whereby it's very high risk to manufacture vaccines, particularly COVID, because you don't know what will happen in 2022 and 2023. And many companies always ask us, where is the market? How much money is there in total? And this is where we come in, whereby in discussions and with COVAX, the World Bank, the Asian Infrastructure Investment Bank, the total amount of resources for vaccines is quite substantial. And now the private sector can come in knowing that there's a market, because they know that we have 9 billion, the World Bank has 12 billion, the AIB has 5 billion, and then these resources also from COVAX. I'll stop there.
No, I think that's a terrific point. And, I think one question in all of this is sustainability of these private sector health delivery and manufacturing enterprises is the demand side. Who's there to buy it? Is there a purchaser where it's affordable, it's sustainable, and they want it? And that's been a challenge with vaccines. I think hopefully the financing is in place now, but I think that's something we need to consider across all of these investments, right? Who is the buyer, and is that a sustainable buyer? And working with them early on, working with PEPFAR, working with the Global Fund, working with national governments and large private sector health providers to understand who will be buying this and what are they looking for to make those sorts of procurement decisions. So changing tacks a little bit, I want to go over to Mara Hansen-Staples to think a little bit about the demand side of all of this from the perspective of companies that are engaging in the private sector for health innovation and delivery. Mara is the founder of Salient Advisory, which conducts analyses and supports partnerships to use technology, innovation, and financing reforms for access to healthcare. So what do you see in this space? What are your clients, the companies you work with, what are they looking for from the DFIs? How can they best be helpful?
Thanks, Rachel. And I just want to echo Nafisa's comment that I think this is a real moment of opportunity for DFIs. So as you said, at Salient, we track over 1,200 health startups in Africa working across delivery. So these companies are doing things like digital counseling, appointment booking, telemedicine, software for hospital and pharmacy management, product distribution, counterfeit, drug detection, and much more. And this space is really growing. So 60% of the companies we track were founded in the last 5 years, with 2020 birthing the highest number of companies by a long shot. So it's really exciting to see local entrepreneurs seeing commercial opportunities to solve for some of the challenges we within the development community have long tried to tackle. But as we all know, it's a really tough business environment. And to your point, Rachel, with no promise of large-scale public purchasing of their services, they really face an uphill battle. Though the needs of these entrepreneurs are many, and the challenges of supporting businesses in healthcare delivery are also numerous, I'll flag just 2 considerations for DFIs today. First, growth stage financing for health tech companies remains really limited and highly concentrated. So as these cohorts of innovators begin to mature, DFIs can continue to spearhead investments in growth stage companies in both supply chain and healthcare delivery more generally, building off the kind of investments Nafisa's team has made in companies like mPharma and Kasha. Critically, where grant makers have expressed a desire to support more local businesses, I would encourage DFIs to lean into these partnerships to help direct grant capital more effectively to support your investments and business growth. Secondly, as Soren mentioned, startups really need access to affordable working capital. Though partners like the Medical Credit Fund in Africa are successful in extending access to debt for health SMEs, the costs of the loans are very high. So a similar mechanism that pairs specialized risk assessment with funds raised in local currency could reduce the costs of currency hedging, thus decreasing the costs of these loans and helping extend affordable working capital in both healthcare supply chains and care delivery. So thanks.
Terrific. Thank you so much, Mara. That's, I think, very helpful framing. Over to John Simon now. John is the founding partner at Total Impact Capital, which works to structure investment vehicles that maximize impact while reducing risk to a broad range of investors. So I think a similar question for you. What are you seeing in terms of demand, of the gaps and the kinds of financing available? And where do you think the DFIs can do a better job offering responsive products that support the needs of emerging businesses?
Thanks, Rachel, and thanks to CGD for pulling together such a great discussion of friends and colleagues. I would say one challenge of being on such an illustrious panel is, everyone has said most of what I might have said before, so it's a bit of a challenge to find something insightful at this point. That being said, I do want to go back to Julia's opening presentation, talk about a few items there that I think are critical in terms of thinking about how DFIs can add value at this critical time. The first was the point about trying to support UHC, particularly through comprehensive and resilient health system strengthening. The commitment to SDG 3 makes UHC something that governments across the globe are trying to achieve. That being said, as Nafisa pointed out, the financing gap is massive. That financing gap absolutely at 300+ billion cannot be covered by what's available in the public coffers, cannot be covered by what's available through official development assistance. It has to come from the private sector and not DFIs alone. But that goes to the second point or the third point that was on Julia's slide of where DFIs can go, which is really being part of collaborations that mobilize other capital into the mix. And I think when we think about mobilizing other capital in the mix, obviously we have to think about mobilizing other investment capital, but we also have to think about coordinating and leveraging the other sources of funding that exist there, including the foundation capital that's available, including the large-scale funders of global health today, like the Global Fund or Gavi or PEPFAR or PMI, and really trying to create a capital stack that utilizes all of these sources of funding to allow 1 + 1 in essence to equal 3, because we're not going to get there without that type of new math. And I think as we go on this conversation, we'll talk about the idea of blended capital on both the supply and the revenue side. And I think it's essential to be able to leverage capital in both places. I think right now, though, it's important to recognize the critical role that DFIs can play in putting not only their capital into the mix, but also their analysis and their name. That, you know, a lot of the capital that sits on the sidelines will only come forward if they see that there's a trusted partner with whom they can co-invest. And the DFIs offer the experience and the knowledge and the capabilities to provide that trusted brand. I think to some extent, with what Merck for Brothers is doing with moms, they're leveraging. You know, Merck for Brothers has lots of capital, but part of what they're able to do is leverage the analysis and the processes that a DFI is bringing to table to mobilize additional funding. And, you know, from our perspective, we're working, for instance, with the Health Finance Coalition, which is bringing together corporates like Philips, foundations like the Rockefeller Foundation, the Gates Foundation, the Skoll Foundation, and some of the major global health funders to try and bring together this consortium of players who can actually mobilize capital into this arena. And just a last point, I think to Soren's point, that, you know, it's not just one area. If you're thinking about building a comprehensive health system, you have to think about what you can do on the supply chain side, of course, but also the care delivery, also the finance, also the insurance side, also the project finance, how you work with public-private partnerships with governments, and how you work to support private sector entities to get to a scale, to get to a point where they can actually achieve scale and get that flywheel moving, so you can really reach many people.
Thanks so much, John. So I think we're going to transition now to a more open discussion, and we want to invite the audience to also participate in that discussion. So as a reminder, you can all submit questions throughout today's event via YouTube comment, on Twitter using the hashtag CGD Talks, or by emailing events@cgdev.org. So we hope to have this be an open, dynamic discussion, and please get involved as audience members as well. And I see that Marianne has her hand up, so great to kick this off. Marianne, over to you.
Thank you so much, Rachel. I can't help but comment and just be so excited about what we've heard today. You know, Nafisa mentioned it's a special moment, but I think it's a special moment for another critical reason. We've talked about how we are all working together to build the right type of capacity. And we're all working together to set the conditions, you know, for large scale public and sustainable purchasing. But for me, we've actually changed the paradigm about who is buying what from whom. And the fact that we are investing in local capacity, we are investing in local solutions. Our response to the devastating impact of the pandemic and the effect that it's had on lives is actually supporting the building of livelihoods and supporting economic recovery and resilience in these communities. And I think we are in a moment in time in this world where people are paying more attention, you know, to issues of broader equity and broader inclusion. And I do think that the DFIs have played such an important role in changing the balance of equity and inclusion in global health by investing in local economies, local solutions, and local entrepreneurs. The other thing I would want to say is, and Patrick, you know, you mentioned this when you talked about what's happening in India and the linkages to UHC. This relates back to, Rachel, your question about equity. We do have to continue to be mindful. Again, what are we buying? We need to make sure that we're buying quality and that we are we are enabling the conditions that, you know, for local communities to actually buy and purchase quality. Because if we don't help to put those conditions in place, you know, where these services actually have some kind of quality controls, certification, accreditation, you know, through partnerships with governments, we are failing, you know, the people and the communities that we're hoping to drive social impact around.
Yeah, thank you, Marianne. I think that's a really, really important point on quality. I mean, both for medicines and pharmaceuticals, and that gets to the broader question of manufacturing, and then also for delivery. I mean, this has been one of the critiques of the role of the private sector in healthcare. Obviously, it's a very diverse association or group of providers, but the quality has not always been there. And you have people paying a lot of money and not necessarily getting a lot on the other hand. So I think you could frame it as pro-equity just to say, to the extent that that money is being spent, let's at least make it useful. Let's at least make it for goods and services that actually deliver health value. And then we can also think about the sustainable financing and equitable financing. Mara, you have your hand up. Would you like to chime in here?
Yeah, I just wanted to echo Marianne's point that I do think the tide is turning and there is an opening, but we have a responsibility to go even further in investing in local founders. Our analysis suggests that African founders, and female African founders are particularly excluded. So when we look at a subset of companies in supply chain, we find that most African founders who receive external funding of any kind hit a fundraising ceiling of about $150,000, while most non-Africans who receive external funding raise over $1 million. So I think as we think about who are we investing in to build the health systems of the future, it's really important to think about building a robust pipeline of those founders and companies that are local, that can carry forward the promise of health tech and in the delivery space.
Yeah, you're here. That's a great point. I see a lot of hands up. All right, so over to Soren.
Thanks, Rachel. I mean, just a quick reflection building on, I think, the very important exchange about how we invest locally and we strengthen the private sector offering in the healthcare sector in developing countries. DFIs, of course, finance things that are meeting a local demand or that are meeting a regional demand, and we don't finance that demand, so to speak. But of course, the owners of DFIs are also major contributors to global health finance more broadly. And I think we really need to also ask at the same time, are we doing enough to localize procurement, service partnerships, and so on with what is financed out of the big global health agencies and the global health donor agencies? I think there can really be a synergy between DFI supporting entrepreneurs and service delivery and industry locally, if more procurement and supply is also taking place locally.
Yeah, that's a very important point. I mean, I think the demand side has too often in the past been neglected, not just by DFIs, but more broadly in the sector. And I think it's interesting, for example, with PEPFAR's localization agenda, to think who are the vendors who could be delivering those services. Now, a lot of that's going to be nonprofits, not necessarily for-profit healthcare delivery, but I think we should be thinking about that ecosystem more broadly. John, you're on mute.
On mute. I meant to comment on Marianne's point about quality, but then both Mara and Soren made other points I want to comment on, so I need to expand my discussion. So first off, on the point about quality, that was actually a major barrier when I was at a development finance institution to being able to invest in healthcare, because we had this sort of policy that we had to invest in things that would pass the minimum quality standards here in the United States, which frankly was very, very difficult for investments in frontier markets to achieve. We were able to break through that with something called SafeCare, which was a quality certification mechanism developed by the Farm Access Foundation that was geared towards the conditions and resource constrained settings. And I think being able to have quality metrics that are appropriate in the context that allow DFIs to meet their obligations to deliver investments in high quality entities, and yet not set the bar so high that no entity in a frontier market can meet it is critical. The interesting thing is, thanks to SafeCare, not only were you able to create a both rigorously measured and manageable bar for investments to meet, but also those investments perform better, because as the enterprises strove to meet the quality standards, actually also had to better manage their businesses. And the better enterprise performed on quality, the better they actually performed on business. And now there's a tremendous amount of data in terms of what is happening on the ground that comes from these types of quality metrics that I think with the new data-driven business models is able to be put to use to really help create new enterprises and new opportunities. Moving on to Mara's point about the need to support local entrepreneurs, I think that is essential, but also that requires supporting local capital providers, local fund managers. And so part of what we're trying to do with the Health Finance Coalition is support a new financing vehicle in Africa, a new fund, the Transform Health Fund, that would invest in these high impact opportunities in things like supply chain and innovative care delivery, managed by one of the premier locally based African private equity firms, AfricanVest. And then on to Soren's point about the need that if these investments are going to succeed and are really going to have an impact at the bottom of the pyramid, they need to leverage and this is all what was part of our double blending paper that was referenced in Julia's piece. They need to leverage the resources that are out there already. You know, the Global Fund, PEPFAR, Gavi, PMI, they spend billions of dollars a year in health. Often that money is not coordinated with private investment to help create the dynamic where those private investments can be sustainable and profitable over time. And especially when you think about how the health sector is growing in emerging markets, there is this sort of bridge that has to be overcome, that this type of revenue blending, this type of financing can help do it. So, you know, we do a lot of work blending on the sort of creating blended capital solutions on the source of investment side, but you can have a blended capital financing vehicle or a blended capital project where the capital is affordable, but there's still not enough revenue to make it successful and deliver the return to investors. And that's where, if you can tap the existing sources of capital that are there, you can really create a sustainable delivery mechanism, a sustainable enterprise. And if you look at the numbers, it's actually a very small amount of overall spending can make a big difference in the viability of a private investment in the health sector.
Yeah, very important point. And I think this question of how, you know, the demand side interacts with quality is interesting as well, right? Who's the buyer? Who's willing to pay for quality? And I think, you know, PEPFAR, the Global Fund, you know, they generally deal in pre-qualified products. That's obviously a very high quality standard. But for consumers, do they have the information and demand for the quality assured products? How can we create that ecosystem of consumers who are informed, who have reliable quality signals, who understand what is a quality product or a quality service and what is not, and are able to act as empowered consumers to demand the quality product? I think that's a really interesting interaction. Nafisa, over to you.
Sure. I was just going to say that, you know, it's been interesting working over the last year with some of the private companies on this idea of how do you link their efforts to broader government efforts. And we see that innovation is definitely sort of, I would say, almost accelerating at a pace where government doesn't even know how now do I integrate this potential solution into what I'm doing. I'll give you an example. Working with a company who is, I think to John's point, collecting a lot of really interesting data around population health. How can that data then sort of be fed into a government system to really think about where do you need to focus? How do you leverage predictive analytics and AI to really start to see different solutions, either that can be supplemented by the private sector or through government? And I think this marriage between the private sector and government is going to take on a very interesting sort of relationship over the next few years, because there is a desire, I think, from the private sector to have that opportunity to supplement and support government efforts as well. And I think that's something we need to figure out. Again, how do you do that in a much more succinct way? Because it's not, you know, it's been difficult, I think, to link those efforts to date, at least for us. In terms of quality, John, I will like to say that for DFC, it's been great actually to start looking at opportunities where, you know, we can leverage, you know, Safe Care International standards, or look at how do you move forward investments where there may not be a regulatory framework. And I'll give you an example. We have a project focused on kidney care. there's no international regulatory body for kidney care. You could look at a higher standard, but are we just not going to do investments in that space? I don't think so. And so what is it that we can do as DFIs to be a little bit more creative about how do you invest in these types of projects where the regulatory framework may be lagging behind, but you find ways to ensure that whatever investment you are focused on has a bar for quality, has a bar for access, has a bar for affordability. And I think that that's the opportunity that DFIs have to sort of set that standard for sure. But just wanted to share those few thoughts.
Yeah, thank you, Nafisa. Patrick, you have a comment.
Just to reiterate a point that I mentioned earlier, the health sector is changing rapidly and it's becoming very digital, like Nafisa was talking about. The biggest challenge countries are facing is that there aren't sufficient number of digital health experts. And when we look across the entire Asia, 52% of the world population, only one university, the University of Sydney, has a bachelor's in digital health. No other institution as producing such skills. So we are lagging behind. And these are things, a great opportunity for the private sector to participate, because the digital health cannot be done by government. It's changing just too rapidly and requires significant innovation. Second, in our region, for example, Japan would like to hire 600,000 healthcare workers over the next 5 years. And this because the population is growing, is aging, and this aging is a big issue across the region. And with aging, you have more NCDs, so you have chronic illnesses, and these are people that interface with the health sector many times. For infectious diseases, you have malaria, you get your pills, and that's it. You have TB, you treat it for 6 months. If you have cancer, you're perhaps going to interface with the health sector for the next 30 years of your life, for instance. And this requires a lot of healthcare support and also digital health to be able to, so that you don't have to be going to the healthcare all the time. And so as we think about the changing nature of healthcare, we also need to think about what are the kind of interventions that require various stages to be able to support this sector that is changing. Even in Africa, last week, the president of Kenya and the Prime Minister of the UK met and discussed that the UK would like to have nurses from Kenya. And we're seeing this, the European countries also want to get nurses from Africa. Of course, there's a shortage of nurses in Africa and so on. So this is the dynamics is changing. And I think as DFIs, we really need to think how to support developing member countries to address some of these challenges that are emerging. Over.
Yeah, it's a very interesting topic. I mean, does anyone else have thoughts on that? The role of DFIs in sort of the health workforce, training pipelines, making existing resources go further? Marianne.
Yes, I mean, I think that that's actually the next big gap we need to figure out. So we've talked about how we are really leaning into building private sector capacity for manufacturing, for supply chain, for digital, for service delivery. We haven't yet talked about it for people. And in many of these geographies, again, people are spending their hard-earned dollars, to enroll in nursing schools, midwifery schools, lab tech schools. And how can we think about ways where we are supporting, again, that investment in human capital and linking it to service delivery? I'd love to sit down after this call and let's figure out how to do it. The other thing I just wanted to add, which was again related to the quality discussion. We've talked about how we collectively are working, to increase investments in health. But I think, and Nafisa, I think you mentioned this a little bit about how exciting it is that DFIs are coming together. I think we also need to be intentional about how we leverage the limited dollars that we have and make sure that we are using them effectively and efficiently. And one way is, and I think I'm talking about the collective philanthropy development agencies, DIFs, is the huge amount of sums, and I think, John, you mentioned this a little bit, that's being spent on vertical programmatic monitoring and evaluation. We should be able to direct those investments into building up local institutions that will be able to, one, let us know, whether quality is being delivered. Let us know what the broad impact, of that service delivery is, across the sectors, and that those institutions last beyond, the life cycle, of the project, of the program. So I think that that's another area of collective advocacy that DFIs can engage in, so that the limited dollars that we have are actually building institutions and structures that will live past the lifetime of the project.
John?
Yeah. I mean, one other point that Patrick made that I want to make sure we didn't lose is the opportunity that's created by digital technology in health. And I think that opportunity cuts across a whole raft of areas. I mean, clearly there's the potential that exists for telemedicine, but there's also the potential that exists for digital health and payments. And obviously the payments structure is a very challenging one in healthcare. And yet, there are companies like CarePay that have digitized payments. And I mean, in the US, I find paying for healthcare extraordinarily challenging and difficult. And yet with digital technology, this is something that can become much simpler, much easier, and can allow you to pool funds from lots of different areas. One thing that the Medical Credit Fund, which Mara mentioned, does is they do digital finance. Now their fastest growing product is a digital finance product that allows clinics to be able to borrow for working capital, within 24 hours, and then pay it back from the digital payments they receive through something like M-Pesa. So I think Nafisa made the point that we have a lot of challenges, but we also have a tremendous opportunity. That I think is absolutely true, and part of that opportunity is a function of what's available through technology, and also, I guess, what's available by rethinking the way things are done. I mean, we were just talking about the human resource gap. Well, I think at current pace, it'll be 70 years before Nigeria would have the same number of doctors per person as exists in the developed world. And of course, we don't have 70 years. So now we need to think about what are other ways to deliver care. What are models that use technology, that use other types of personnel, that use other types of models? How do we do things better? And I don't think anyone in this country can be thrilled with their healthcare system. How can we maybe find a better healthcare system in terms of the types of investments that we can make in new markets?
Yeah, we don't want to replicate our mistakes. I think that is a very important word of caution. So, I think picking up on this point about digital health technology and training in digital health and the lack thereof, I think there's a broader question here about how do we create an enabling ecosystem for entrepreneurs in the health sector to have ideas be nurtured early on, have the skills and capacities to build companies. Do you see a role for DFIs in helping create that ecosystem? Is that too far downstream? What's your thinking?
I mean, there's a huge role. The Merck for Mothers and the U.S. government DFC partnership around the Moms Initiative. What we realized really early on is that we really had to walk the journey, with many of these entrepreneurs along that maturation cycle, whether it was support around business planning, budgeting, forecasting, how to absorb capital, how to build teams. And it was such a great partnership because on the Merck for Mothers side, and I'll just give this example, one of our early investments was in a company called LifeBank, which is a supply distribution company in Nigeria that started off supplying needed blood, to save mothers who were dying from postpartum hemorrhage. In COVID, they expanded, into delivering oxygen and other essential supplies. They also expanded so that they are geographic reach, within Nigeria. So back to that equity issue, they're in very rural and hard to access states, that previously had been left behind. They've also expanded into other countries, in Africa. But I bring that up because on the Merck side, we were able to bring teams from our supply chain organization, that shared experience and expertise with cold chain boxes that they put on their motorcycles, business planning, around supply chain inventory and quality assurance. On the DFC side, and Nafisa, please add more if
Sure.
I'm forgetting anything, but that financial planning, how Mara mentioned, many young entrepreneurs are not getting the investment that they need. Part of that is needing support around doing business plans and venture capital presentations, and your team was so amazing in being able to bring that expertise to this pipeline.
Well, it's funny, Mary, I was going to bring up LifeBank as an example as well, because it's such an incredible story, and it's a clear example of impact and equity in a way that I think that DFIs have the opportunity to really focus on. I think that the challenge is, and I think DFC is really pushing to shift and change, but you need resources to support those entrepreneurs, because there is this time where you've got folks coming from academia, you've got folks coming from NGOs who are well-intentioned, see the issue, want to solve an issue with private sector solution. And that requires time and effort and support. And unless you devote resources to bring people along to where they are, you're not going to see that success. It is very, very difficult. And some of those investments are much smaller than what we're used to, right? So whether DFC does an investment that's 1 billion or DFC does an investment that's 1 million, it's the same amount of effort from our agency, which means that we need to have a concerted, intentional effort to say, this is a priority in the global health sector. If we want to see shift and change, if we want to see the private sector really grow in this space, it means that we're going to have to make some difficult decisions about our own resources and where we devote them so that we can see that shift in the next 10 years, 20 years.
Soren.
I think that's very right, and I think, Nafisa, your point about DFIs also having a strategic approach where, on the one hand, we support entrepreneurs who are starting out and have innovative and promising business models, but we also need to stick with them, because one of the biggest, and I would really say in the healthcare sector, one of the public goods that exist when you build a strong company that has the capacity to continue to grow is that you also build the capacity to have better quality assurance processes inside, have better standards for what your employees do, and to build the skills of your employees. And so DFIs definitely need to work with entrepreneurs, but we also need to allow ourselves to work with the companies that are longer into their scaling journey and can be very reliable partners in the healthcare systems. And that's of course also the case in industry where requirements are also immense. But I don't think we can definitely not wait for education systems and regulators to solve it all for the private sector. We need to know that we operate in a scarce resource environment, and that we need to recognize that when we work with the entrepreneurs.
Mara.
Yeah, just to add on to this point about resourcing, I think there's a tremendous opportunity for grant makers to iterate on the way they support the types of capacity building Nafisa and Soren are calling for. Frankly, I work mostly with grant makers, and the structures they have to invest alongside and prepare the pipelines for folks like DFIs are very constrained. Super high transaction costs, a real focus on vertical health outcomes that are sometimes at odds with businesses' growth. So I think it's really incumbent upon the donor community of grant makers to think creatively about how do we adjust our structures to promote business growth and work really much more hand in hand with DFIs to enable these ecosystems to blossom.
Yeah, that's a terrific point. And I think, the question of transaction costs and resources on both sides of the transaction is a big one, how we can make that work and make it worthwhile. I mean, maybe a question for those of you working at DFIs, what about staffing up? I mean, what about increasing your staff size, sort of making, not just dedicating existing resources, but making a kind of concerted play to try and have the people in place to be able to better manage some of these smaller, maybe higher risk transactions?
Rachel, I think at least at DFC, it's been great because we've had administration support to scale up for global health. And I came in being the only person directly focused on global health and being able to support all of our business lines. And we are increasing that staffing, both from a policy standpoint, but also from an investment advisor standpoint as well. And so we've been able to see that success because there's been leadership support to say, look, this is a priority and we have to double down on how we are going to address these issues. And I think it's everything from, how is it that we can look at investments through our TA program, where again, the idea is how do you scale some of these smaller initiatives to looking at long-term debt and what does that mean? And then how do you bring people along? Looking at our funds program to be much more intentional to focus on healthcare. I think that those are the things, at least for our agency, it's been nice to see that aggressive growth. And we'll see that in the next year, 2 years, you'll see this intentional growth, especially around the global health sector space.
Patrick.
This is a big issue. And as an organization, we actually reflecting on this right now, because we looked at our entire staffing and we said, what proportion of our staffing are full-time? What proportion of our staffing are part-time or consultants? And what proportion of the work is being done by consulting firms? And it's about 55% staff, 30% consultants that we hire on short-term basis. Sometimes some of them last 1 year or 2 years, sometimes 3 years, and then firms. And we realize that when consultants come, they're very highly skilled. They come, they get a lot of knowledge working with our member countries, and then they go away with all the knowledge. So we've made a strategic shift that's starting from 2022, and we looked for example, last year we had about 300 very highly skilled consultants. We're going to create those positions and hire them to be staff so that they can manage project programs and also have those skills on staff so that the people who are working are not just managing consultants, they're actually engaging with government, looking at some of the challenges they are facing and sharing that knowledge from one country to another country. So staffing is a big issue that many DFIs are struggling with, and I think that we are trying to solve this problem.
Thank you, Patrick. So we have an audience question from my colleague, Prashant Yadav, who I think probably most of you know well. And he says that, from this discussion, seems like there's quite a lot of agreement among us. I'm sort of extrapolating on his question here, so not putting all these words in his mouth. But the problems, the opportunities, the solution set seems pretty clear. So what is actually preventing us from moving forward in a significant way? What are the barriers here? John.
It would be nice if we could all in this session come to a clear program for the DFIs and they could just adapt it. I do think that there are a number of challenges. I mean, as we pointed out before, for a period of time, and as your graph, Julia, showed, DFIs did very little in healthcare. So this is it's great to see Nafisa at DFC leading the charge. But this is a very new area for them that a lot of them need to gain experience. I think DFC is probably ahead of the vast majority in terms of that experience. But there's experience in the sector that just doesn't exist at a lot of DFIs. The other thing that a lot of us have mentioned is the idea of DFIs maybe being a little more risk on in this sector than they have been in the past, and that is an uncomfortable position for a lot of DFIs to be in. And I do think to make the types of changes that we're talking about, they have to be willing to extend themselves from a risk perspective in ways that aren't. I do think that a lot can be done to mitigate that risk with some of the things that we've been talking about in terms of coordination between the DFIs and the big payers of healthcare, and how some of that risk can be taken off on the payer side. And then there's a lot of what we've talked about, which are sort of brand new models of doing business. And whether it's in health or anywhere else. I mean, one thing that when I was listening to the conversation previous to the one about the staffing is people were talking about, avoiding in the, the way that the current funding is so vertically oriented and the way that it focuses so heavily on the cost of monitoring and whatnot. And if we could shift towards more of a vertical funding or revenue funding that's focused on paying for performance. I know when I was on the board of the Global Fund, we were looking very highly at trying to get out of the business of lots of tendering and paying for a product to be where it's supposed to be, when it's supposed to be, with a patient. And if you could pay for that, then a whole slew of businesses can come up that can figure out how to get the product from point A to point B to the patient, instead of the situation now where all that falls on the donor or the government, and they have to manage a process which private entrepreneurs would be more effective, enabled with digital, enabled with technology, enabled with sort of all the sorts of the things that we're seeing in the broader private sector to do. So I think, Prashant's a good question, but I think we have a clear vision of where we want to go. It's going to be a lot of hard work to sort of cut through the brush to get there.
Marianne.
I think it's transaction costs. These are new ways of doing business, new models, and I always say, like, the first phone was 10 times the size of this, and so we have to be patient in that early stage, of working together. That it's going to take time and commitment, and it may seem frustrating and inefficient. And so one of the things actually Merck for Mothers is doing to create incentives for this type of horizontal, multi-sectoral collaboration that supports the pulling in of diverse financing types, diverse types of financing, is a new collaboration we're launching called Strengthening Systems for Safer Childbirth. And it really builds on the learnings of two things. One, our partnership with DFC Moms, where we recognize that while we were having a lot of success around scale and sustainability of the individual innovations and solutions, there was more that we could do to integrate them into government strategies and broader mixed health systems. So that's exactly one of our goals and the way that we've set up this new collaboration to really encourage the identification of local solutions that can pull in multiple types of financing and really complement ongoing government efforts on ground. I think the other place, and I can't remember who mentioned it, but really engaging in more dialogue with the donor and philanthropic community, so that they too are supporting the organizations they fund to be able to receive more diverse types of financing. If you speak to many of these organizations, where they may be called CBOs or NGOs, they're incorporated in that way because often that's the only way that they can get donor funding. And so they almost have to do a on-off switch from moving from donor funding to development, finance funding. And that's scary, for them. And so we need to have more of a gradated on-ramp, around that. And I think the last point, Prashant, around, why aren't we doing, this more, is because I think it's not just the development finance institutions, that are part of the solution. It's also the private capital, and we're still not at a place where across all of these entities we have, we have unified ways.
Yeah, I think that as we look at issues around working across sectors, it's very challenging. And the reason is that there are certain skills that are required that people in the health sector don't have, facilitation skills. For instance, To address issues of road safety, you need to work with the transport sector. And who are the people that work in that sector? Mostly engineers. So now you have a healthcare worker trying to facilitate a meeting of engineers who think very differently. If you think of NCDs, you're talking about mostly private sector companies. You're talking about food fortification, and we are trying to encourage them that they should not make bread that is salty. And in Argentina, they like bread that is salty. And so you're trying them to change their business model and so on. That requires a lot of facilitation. On pandemic preparedness, you're talking to the cultural sector, because a lot of pandemics start from the cultural sector. They think very differently about food, and now you're coming as a health person. We don't have these skills, and these skills are not given to us in medical school or in any of the public health schools. So this is the challenge. We need to train and build the capacity of those of us who work in DFIs and across the health sector to be able to learn facilitation skills beyond the health sector.
Well, I also like bread that is salty, so I sympathize with the challenge of trying to change consumer behavior and preferences in that way. Soren.
I wanted just to magnify Marianne's point that ultimately this is about mobilizing much more private capital for the healthcare capacity expansion and to reflect a bit on the barriers. I mean, the fact is that for DFIs, this is really an emerging sector. It's just a few percent for most DFIs on average, whether it's 4 or 5 or 6, whatever. It's really small. And if we just go business as usual, which is several years of DFIs growing this sector 10% a year, it'll be far too long before we get to scale, and we have demonstrated enough that we also get private capital at scale. So I'm really excited about some of the initiatives that really try to make a step change. I mean, I think putting strong management in place, like with Nafisa at DFC, is one step. I'm also excited about something like what the UK DFI CDC has done with its MedAccess subsidiary, which is basically like an innovation finance hub attached to the DFIs to try and give extra focus and speed. The European Investment Bank has launched an initiative where they combine some of their health sector expertise with financing from their own balance sheet and several European DFIs like the Swedish Sweat Fund to try and do a similar boost. And I think you need, if you want to really be ambitious enough here, you need to do some things that are step change, and that needs to complement the sort of incremental business approach, I think.
Nafisa.
Sure. I mean, I echo what everyone has said. And Marianne, I almost feel like you work at DFC at this point, the way that you were able to articulate what some of the barriers are. So thank you for that. And Soren, I agree. I think that there's been incredible innovation, and I actually look at what EIB is doing around, AMR, for example. That's incredible, and I would love to be able to do that at DFC. But I think that takes time for us to bring the agency along and figure out how do you mitigate risk. And the healthcare sector is inherently risky, and that is why I think that for many DFIs, it's not the straightforward, deal to go to. When your bread and butter has been infrastructure and technology or energy for a very, very long time. And I think that at least for DFC, as we look at what are some of the barriers, we want to see sustainability for some of these projects. And that requires an incredible investment of time and energy, not just from a DFI, but from partnering institutions that will help to create this enabling environment. So if you think about vaccine manufacturing, for example, I know Prashant and I talk about this very often. We can provide the financing. I actually don't think that financing is necessarily the issue. It is everything else that is around that, right? How do you build the expertise for a management team to be able to, manufacture vaccines at scale? What does procurement look like? What does the regulatory environment look like? And those are pieces where the DFIs are now starting to have a dialogue with partners that we really haven't had to dialogue with before, right? If I look at our investment with Aspen or BioE in India, those are a lot more straightforward because the enabling environment is there. So that, that investment is a very different investment than looking at maybe Senegal, where we're starting off with grant funding and really thinking about, step by step, how do we support this institution that's really trying to expand capacity in a way that they've never done before. So I think that to John's point that he said, there's patience that's required, but there are also some real barriers and I think opportunities for us to figure out what is the relationship between a DFI and some of these other global health institutions that are really also trying to make an impact as well.
Yeah, and I think a challenge for everyone is to marry the required patience, understanding the complexity of the situation with the urgency of making some progress and getting this right. So it's a balancing act between those two imperatives for sure. John.
The one barrier that has not been mentioned, I think it's very worth mentioning, is the need to develop investable deals. I mean, the need is massive. We've talked about the need, but the availability of deals, of opportunities to move private capital that are actually meet a reasonable standard of diligence, that pipeline is relatively small. There obviously are deals out there. There are a number that have been developed, but to hit the scale we have, there's a lot more work that needs to go into that on the TA side, on the arrangement between public and private sector to develop these deals, and on what we call with the Health Finance Coalition, basically deal construction. That deal construction effort, which is very active in other sectors, really needs to be ramped up in the health sector if we're going to not only be able to mobilize all the capital we're talking about it, but actually put it to work.
Here.
May I come in on that?
Yes, please, go ahead.
Yes, I think that what John has said is very, very critical. And this is where PPP programs come in place, because DFIs can use sovereign money to support a very serious analysis of the sector and identify what are the bankable projects, and then the private sector can come in. And the DFI they also have technical assistance grants that can actually do that. Over.
Any other thoughts on how to build that pipeline?
I think it's the collaboration from the beginning of the R&D and discovery cycle, all through the scale and sustainability cycle, because, I think I often say, money is important, but it's also the right type of money. So if all of us donors and DFCs and philanthropists are funneling money into, just this certain segment, of the cycle from discovery to scale and sustainability, that is inefficient. Let's make sure we all have a 360-degree understanding, of the sector, and target academic money or government money to R&D, to building those organizations up to a place that they can absorb, these types of financing. Target donor and philanthropy, to the integration and the human capacity development, needs. So I think that there is so much opportunity for us to look at this sector more holistically, and think about where our specific types of financing can do the most good and help propel, these solutions, across that continuum.
Yeah. Just to build on what Marianne is saying, we focus on mostly these entrepreneurs who, to John's point, are not quite deal ready for folks like DFIs. And we see sort of three opportunities to better bring coherence to the support they're provided on the philanthropic side. The first is to sort of marshal coherence among the grant makers in this space to allow them to provide the types of TA you all think is critical. The second is to have better partnerships between these entrepreneurs and industry actors who can help bring them to scale. So folks in the pharmaceutical industry as well as technology. And the third is to establish partnerships between these entrepreneurs and, in the case of Africa, where I focus, African institutions that can help them navigate the tough regulatory environments that are important to navigate to go to scale, both within country and across countries, to enable that real regional reach that will represent sort of true scale and viability for many of these health tech businesses. So I think, pre-deal, if we could bring those three pieces together, industry, institution, as well as highly risk tolerant grant financing for that capacity build, I hope we could help propel some of these entrepreneurs towards investment.
And then Mara, I think to that extent, being able to really communicate about what are the eligibility requirements for any of these projects, right? And being very, forward leaning about communicating what that looks like. I think that's been helpful for us. And I think, Marianne, we've learned a lot from the Moms Initiative in doing that too, but really getting a clear sense of here's what eligibility looks like for a DFI. And, if it's equity that's needed, maybe there's another appropriate DFI that can provide that. Whereas DFC, we're really going to be, our sweet spot is debt financing and political risk insurance. And we're just now getting our equity tool up and running, or just now getting our TA tool up and running. But how can we partner with other DFIs? Because at the end of the day, I know I would probably, say that Seren would agree, and Patrick as well, is that we want to see more investment in this space, regardless of which DFI ends up doing it. That is the end goal.
Yeah.
And so how do we start leveraging and working together so that we're sort of unified in that goal to push for private investment? There will be deals, they'll come, but really being able to leverage and work with each other more intentionally, I think, is going to be important, and also in communicating what those eligibility requirements are.
Well, we're just about at time. I think that's a good note to end on, the importance of getting this brain trust back together to work together collaboratively. And I'm very pleased with this discussion. It's a good discussion when you have questions written out and you don't have to consult them at all, because we're all building on what everyone else has been saying. So again, I really want to thank all of our panelists for their contributions to this discussion. I'm going to thank Julia Kaufman for her initial remarks, which really helped set us off on a great note, and our entire team at CGD for helping put this event together. Thank you so much. We hope you'll join us again for our next event. And I can look forward to continuing this conversation with all of our panelists and the broader community.
Thank you so much.
Thanks,
Thank you
Rachel.
for the opportunity.
Rachel.
Thank you.